have got this from a cardiac surgery. I'll hand over to Mashrafi Bhai to go through the panel of the cardiologist. Thank you very much,
Thank
everyone.
you. Thank you, Asif. Asif and I were almost at the same time. We're in the Dhaka Medical College. We were 1 year apart. And Asif has really reached to such a
I'm the young one, by the way. Yeah, it doesn't look like, but that's true.
yeah, that tells you that you are a good, good hardworking surgeon. For the doctors, the gray hairs is the pride, right? Uh, so let me introduce. I have Dr. Shafiq from United Hospitals, and I think Dr. Kaisar Nasrullah sir as well. Assalamu alaikum. Dr. Nasrullah, how are you, sir? Sir, you are probably muted. Could you please unmute yourself?
Yeah, thank you so much for organizing this such a wonderful webinar by PHA, and you're doing a wonderful job. And we really learned a lot from this type of webinar. Thank you so much for coming back to the country and training our junior doctors and us as well.
Thank you, sir. We have Dr. Shafiq from United Hospitals and Dr. Kaisar Nasrullah from United Hospitals as our panelists, and Dr. Chaudhary H. Hassan, everyone knows, we know him as a Hafiz Bhai, and he's one of the pioneer and trustee of PHA. And thank you for joining in your busy day. It looks like you are rounding in the hospital. Hafiz Bhai, please say 2 words first.
Thank you. Happy to join. And Farooq Bhai, Assalamualaikum. Dekhe ko bhal lagse. Kaisa ki kaun aso?
Bhalo, boss. I'm good.
So with this introduction, thank you for all our panelists to be here, and we will start presenting a couple of cases and open up after a presentation of that case, we will open up the discussion for the forum. And I will encourage all the participants, cardiologists, cardiac surgeons, or any physicians, if you have any questions, raise your hand or put it in the chat box, and I and Asif both will try to address them as much as possible during the course of this discussion. So with that word, I would like to invite our 2 speakers here. Let me introduce these 2 speakers as well. I have Tanveer Ahmad from United Hospital. Tanveer, I came to know him, this brilliant man, when he first he was awarded with the first fellowship award from PHA. He came to USA to get hands-on training, but then an unfortunate event happened, and then he had to return back home to his family within a very short notice. But I'm hoping that we will get him back again and fulfill the training and the exposure that we sort of promised to him. And then we have Nilesh Gupta. He's the chief fellow. Long journey, Nilesh. I know we all have gone through that long journey. So you look amazing. You're going strong. And thank you for being here and coming up with a presentation of a complex case today. We will have a good discussion. I bet, no doubt about that. Thank you very much for being here with us. With all this, I would like to start with our first presentation in the case. And did you guys decide who is going to do it? Is it Tanveer or Nilesh?
I yield to my senior.
Okay, all right.
Yeah, so I can start.
So Tanveer, go ahead, please.
Thank you. So I'm sharing my case. Is it visible here?
You start. Yeah, you are good. I can see you.
It's from the case where there will be sort of more of discussion on what to do regarding the decision making rather than the complexity of the PTCA procedure. So I'm Tanveer Ahmed from United Hospital. So I'll start with my case. It's about a 62-year-old gentleman, is diabetic hypertensive, and presented with class 3 angina pain. And he was on optimal medical therapy for last 2 to 3 months. So if you see his background history, he had an MI in 2010. He had triple vessel disease. CABG was done in 2010. And he had 3 grafts, one from Lima to LED, RSBG to OM, and RSBG to distal RCA. So the creatinine and all the parameters were normal. We can see the ECG, old inferior MI.
Tanveer, your I don't know. I at least do not see your screen moving. It's still your first page.
Is it moving
Now
now?
we will go to presentation mode.
Is it moving, sir, now?
Not
Yeah,
yet.
Tanvi, you're sharing your PowerPoint, but I think you have got a full screen somewhere else, which we can't see. So I can see your
You
mouse
can go for
now.
presentation mode. Right. Presentation mode.
Yeah, I'm in the presentation mode. I'm just sharing it again.
Not still.
Now, now we can see you. Now we can see you. So go ahead.
No, but not in the presentation mode.
So go to the slideshow maybe on the top of your screen and
Right.
start the presentation there.
Is it moving now, sir?
Not yet.
Not really. Or you can click on individual page to see if it comes up.
Yeah. It's moving now?
Yeah.
Yeah, so it moved now, right? So I think you have to click individually on the things as it's not moving forward.
Is it visible now, sir, the echoes?
But still it is not in the slideshow. You can go to the slideshow.
Yeah,
I
it's
think.
in the slideshow mode, but I'm seeing
No.
it in the slideshow mode. Okay, I'll just show
Individual.
individual pictures. Okay, so this is the picture of echocardiography. And then we did the coronary angiogram. So the coronary angiogram, as we can see, there is a distal left main lesion and lesion in the proximal LAD and SARC. So if I go to the still picture here, the LAD is totally occluded from the middle part. And there is a tight lesion in the distal left main. We can appreciate the size of the diagonal and the big septum. The arrow marks are actually showing the site of the lesions and the blockages. And then if we see the Lima graft is patent. And it is supplying the distal part of LAD. The problem actually what we are facing is the Lima graft was not supplying the territory in the proximal and mid part of the LAD where we had a big diagonal and a septum. Similarly, we can see severe osteal disease in the LCX and no retrograde filling coming from the RSBG to the OM graft. So this is the RSBG to the OM graft, where we can see there is some tight lesions in the venous grafts in multiple sites. The RCA native vessel was totally occluded, but fortunately, the venous graft to the RCA was patent. So here we had a scenario where there was a native TVD with severe left main disease. Graft vessels were patent with some lesions in RSBG to OM. RSBG to RCA and Lima were almost normal. LED was totally occluded from the mid segment. But the problem, the scenario which we were facing right now, we are having a huge diagonal, a big septum, and a shark with osteal disease, getting no retrograde filling from the grafts which were inserted in the distal part of the LED and distal OF. The patient was already on class 2 angina with optimal medical therapy. MPI could not be done at that time due to the COVID and all those reasons. So we had to rely on the clinical symptoms and angio finding. So what should be our strategy in this part? Should we keep on medical therapy? Should we go for a PCI? Should we go for redo CAV? So coming to that, I'd like to throw these questions to the panelists.
Okay, so let's ask our respected panelists, what questions do you have particularly for this case more that we can clarify?
Okay, sir. My question was, this patient actually presented with anginal pain class 3, and he was on optical medical therapy. We did the angiogram. We have a patent lima. So that's where we have the dilemma. So if the lima was diseased, redo CABG would be a very important and viable option. But in this case, even if the lima to LED was patent, we can see in the picture here, the diagonal and the septum is quite big. And the lima graft to the LED is actually supplying just the distal 1/3 of the LED. So what should be my options in this case, sir, for the revascularization strategy?
Righty. Hafiz Bhai, do you have any questions or comments on?
No, I think the revascularization, I would not think about the redo cabbage, as Tanvir pointed out. But question is for the revascularization of the left main and then the proximal LED into the diagonal, that will help or not. The clinical presentation, if I understand, was unstable angina / ruled in non-STEMI.
Yeah, and non-STEMI ruled out, sir.
Oh, okay. So, but the question is how symptomatic and
he was quite symptomatic. He was quite symptomatic, and we were keeping him on optimal medical therapy, but still his quality of life was not quite good to maintain a normal activity.
So then he declared himself. So probably need to do the, percutaneous revascularization. And question is, what is the strategy after you are recommending PCI? And that will be the somewhat protected, I would say, the distal left main. So this is not truly the left main. It's this somewhat protected left main.
Somewhat protected left main, right?
Right.
Can I just ask Tanvir, very nice presentation. You mentioned about you actually showed a view on the echocardiogram, but there was a very short images I couldn't see properly. Was there any regional wall motion abnormality on the echo?
So some regional wall motion abnormality, mainly on the lateral walls. Septum interior were quite okay. We could not do an MPI.
All right.
So that was a limitation.
Okay. I mean, I just want to make one point, and then I'll ask Farooq sir to see if he agrees with that. The indication for redo cabbage has to be very clear. I mean, in this sort of targets, you really don't want to go for a second operation unless there is a strong benefit, because the surgery itself has got its own risk. And when you've got a patent limit with a very good flow, and you have got a patent vein graft with some graft stenosis, which can also be easily addressed by stenting, if I'm not wrong. So I think redo cabbage is not going to be in his best interest. And I would strongly agree with Hafiz Bhai as well that this case would be the one, because you've got a lima to LED now. So basically it is protected downstream. So you can actually work on the left main and the diagonal less riskier than at the first instance. Farooq sir, but I don't know whether you would agree that I don't think this patient should have any redo cabbage.
I do 100% with Dr. Hafiz and Asif with you, because if I am the surgeon, I would have recommended, or I have my recommendation will be optimized medical management plus minus PCI. So that should be the option, because all the three gaps are working. And what I see after CABG patient, in the first shot of this angiogram, when I don't see the native bases, then I become almost sure that the grafts are working. When the grafts are not working, then the native bases become prominent. When the native bases are not there, I cannot see them properly, then probably the grafts are working. Here, limit to LED is okay, the PDA is okay. And some flow limitation may be there due to, because of this irregular narrowing of this graft to the OM. So, and seeing the faces, to me, it looks like patient is probably diabetic, long-standing diabetes, probably.
Yes,
Do the patient have diabetes?
yes, sir. Diabetic.
And prime importance is to control the diabetes strictly. And at the same time, using the statin high dose. And I will prefer this optimized medical method plus minus PCI, 1 or 2 stents, probably patient will be benefited.
I have a question that the patient originally had any vein graft to the diagonal or no?
No, sir.
So we have the previous film, because the more and more we are championing this idea of complete revascularization. So if there was distal left main and prox LAD at that time, and I think it was prudent to pay attention to the diagonal, because the diagonal is pretty respectable size. So I'm just curious whether diagonal got a graft in the first place.
No, sir. The diagonal didn't get a graft in the first place, and CABG was actually almost a decade long. So we don't have the CDs, NGO CDs of the first graft. So that graft to Lima was actually placed in almost the mid to distal part of LED.
Yeah, and Tanvir, I mean, I just want to highlight what Hafiz Bhai was saying as a surgeon is really, really important. And I'm sure Farooq sir would agree that when you got disease on the LED and you are grafting on the distal LED to the lemur, it's not going to go back into your septal or the proximal part. And if you got a decent size of diagonal in a patient who's got distal left main, we really need to address that, because people usually think diagonal, I mean, you graft it doesn't make a huge difference. But in this sort of cases, that makes a huge difference. Basically is going to retrogradely feel the septal and this. So it depends on what was the first angio. Maybe they did not have significant lesion at that time. That's why probably decided to leave the diagonal, but we can never say. But in generally speaking, Farooq sir, you will probably agree that if you got a distal left main lesion and a big diagonal.
Yeah, if a good diagonal is there, that should have been tested.
Exactly, yeah.
Differently, if there is any proximal lesion before the diagonal.
Right. I cannot agree more with this, because of, although we haven't seen the previous angio, but this distal left main, which is in fact the inflow for all these blood vessels, and this diagonal is quite a good size diagonal. So probably should have gotten a bypass at the very beginning in any possible way. Here, I think the challenges would be, and I agree with Dr. Chaudhary that this is, all three grafts are patent. I think this is not going to be a surgical candidate, definitely. The question here is, if I look into these pictures, there will be a quite significant challenge just because of the size mismatch. I do not know how was the size of the diagonal. Definitely we'll probably need some imaging to see what is the size of this diagonal and what would be the size of the left main body here. But there will be a quite significant size mismatch if you want to do a PCI there. So before approaching the PCI, I think I would first focus on whether the patient is maximized on multiple anti-angiolal therapy or not. That would be my first thing to really focus on. So is he on multiple anti-angiolal therapy, at least 2 anti-angiolal therapy, Tanvir?
He was actually on 3 drugs, sir.
Okay.
He was actually on 3 drugs, and considering the complex lesion, we also, our first plan was to keep on medical therapy.
Right. Because
Sir, I had a question in this sort of scenario
Sure.
for my cardiac surgeons, sir. In the era where you are doing lots of minimal invasive surgery, say I didn't have the disease in SARC, would you consider anything in this case for the diagonal?
Zima.
Sorry, Tanvir, what was the question? So if you don't have, if you didn't have any on the circumflex.
Yeah, it was just the diagonal and the patient was as symptomatic as the patient is doing now. In the era where you are doing lots of minimal invasive surgery.
Okay, okay. Redo surgery for a graft to the diagonal.
Yes, sir.
Yeah, I mean, I still think that redo surgery in a context of previous cabbage surgery, where there is always a risk of damaging the lima, I would probably say, I mean, Farooq sir has got loads more experience about doing redo surgeries, but in my opinion, I would say that, as he agreed, optimize medical followed by PCI. If none works, then definitely we do redo surgeries, and that should be the last resort.
I have a question here. Well, actually, the size of the diagonal still after definitely size would be much higher because it is not being nourished by the by blood. So because there is a tight lesion in the distal left main, so diagonal would be maybe 2.5 vessel, but still it is seeing the vessel size. It could be 1.5, not more than that. In that case, to accommodate stent, whether it would be possible. And not only that, two stent strategy would be difficult in this case. So in that case, L6 might be jeopardized. That could be another problem for PCI.
right. I completely agree with that, because the size mismatch will be a thing, and then definitely with this sort of small vessels with small stents, two stent strategy probably would not be a long-term benefit at all. That may just add more complexity for future for this patient.
Oh, sir, can I just show it a glimpse what we actually had to do and what we did, sir?
Sure.
Yeah, so as the slideshow is having some problem, I'm just going with the still slides. I'll try to show it here. So as you said, we went for an IVUS for the left system. So we did an IVUS of both the diagonal and the SARC. It was showing quite a bit of plug burden in both the proximal parts of the diagonal and the LCX. You see in the LCX, there was some calcium as well. You can see it in the mid part and in the proximal part. No definite nodule. This is a IVUS run going on for the LCX. Some calcification, but not something which we would go for a ablation. And then the left main was also significantly diseased, especially in the distal part. So we actually, considering the size, we decided to go address both upfront. So we went for a decay crush. So sir, as you were saying about the size discrepancy, we had the IVUS to guide the size. So we used the cutting balloon, considering there was a tight lesion, some calcifications. We went for a decay crush. I'll not go for the technical aspects, as this is more of a discussion based. This was the NGO view. Is the NGO view visible, sir?
Not visible.
Okay, I'll just show the final shot. This was the final shot.
Still not visible.
Is it visible now, sir?
No.
No.
The slides are not visible when I'm running them.
You may need to go to the presentation mode.
Sir, I'm in the
get this
presentation mode actually, but
It doesn't work.
Okay, so we actually had a good result finally, and the sizes were quite huge. So we used the stent size and balloon size 3 and 3.5. The angio views were actually showing the LCX and the diagonal were quite underfilled. And the IBUS was showing the vessel in LCX was 3 to 3.5, whereas in the diagonal it was close to 3 because it originated from the proximal LED. So once we opened up the vessels, we did the IVAS, we did the DK crush, and then we optimized the size using the IVAS again. So final shot, the diagonal seemed almost quite near to the size of LED. So the patient, we talked over the phone before a week, and he's doing fine. He's still kept on anti-anginal, but a single anti-anginal, and he's doing fine.
Excellent job.
Just a quick question, Tanvir. You showed on the angiogram there was disease on the vein graft to the circumflex.
Yes, sir.
When you opened the stent, did the whole circumflex opened up, or did you have to do anything on the vein graft?
Sir, I'll just show you picture, interesting picture for the graph. As you can see, there is a disease in the distal part of the LCX, and the graft was put actually in the last OM. So it was not filling any part of the native LCX from the very beginning. So
Right.
so it didn't actually have any effect on the circumflex flow.
No, my
Now
question
that
was.
you have fixed the ostial proximal circ, overall, I think you will be okay. I think.
Right.
It's almost a year now, sir, and the patient is doing fine.
Yeah.
We didn't
I
definitely go for a relook CHE or something. We just talked about the symptoms, and he's doing fine with one anti-angina.
And I was dying to see a final shot of in the
Right.
diagram.
I wanted to see that final shot.
I will just check whether I have a still picture, sir. And
Or you can do something, Tanvir.
after you did that
can,
final kissing balloon, if you did an angio shot like the second picture, let's see if the second one runs or not.
and just it's not running.
Tanvir, do you have all the videos saved in a separate file?
Yeah. It's
Yeah. So
it was something I presented.
That's fine.
It's running in my laptop.
Yeah, so what I'm
but
saying that if you unshare your slide now,
yes, sir.
and you can just separately share the videos.
That's what I'm
then
trying,
you can-
sir. I'll just unshare and
Yeah.
I'll just share it again, sir.
So share the videos only, and then
Yes.
hopefully we'll be able to see the end results.
Now, in the meanwhile, one quick technical question I want to ask to the surgeons, Dr. Farooq sir and Atif. So hypothetically, suppose if you get this patient as to do the first cabbage, and you see that there is a big diag and LAD, would you prefer to separate, put an SVG graft to that diag, or would you prefer to do like a lima and touch both diag and LAD, which would give you the better result, like a jump graft with lima?
Yeah, and that's it. Farooq sir, do you want to comment?
Well, one of the criteria for this jam graft or sequential graft, the graft should have proximal tight lesion. If the lesion is very tight, not very tight, when I put the graft, then it's probably not going to work and getting occluded in a short time. So if it is not very tight, then vein graft, and if it is very tight, then I can do a sequential or a jam graft, whatever this is.
Mashur, just to tell you that the hemodynamics, the way it works, if you've got two separate lesions, you've got a two separate flow there. So unless you are definite that both of them are obstructed flow, and if you put the lima share them, then where the flow is actually less resistant, that will get occluded, and the one that will get flow. And if it is the diagonal, then your lima to LED might go down. So it's a bit risky practice until unless you're definite. definite. My practice, I don't do that. I just put lima to LAD separately. And if I need to put a separate arterial graft, I use the REMA or I use a radial artery if I need to do that. But I would leave the limas only for the LAD.
Only for the LAD. Okay, great. First,
Excellent point. Excellent point. Dr. Morton Kahn, the guru of physiology, he has actually says the same thing, that it is better not to uh, compete with the flow in the lima to the LAD. It's a very important part. I just wanted to point out, because we may have some junior surgeons in this group, and Farooq Bhai, you can please correct me as well. Sometimes we see this thing that the high grade stenosis and the diag is not filled well, and there is a tendency for us and for the surgeon to downplay the size, and therefore we said, okay, we're not going to put any graft on the diagonal, but the high grade stenosis might be fooling us. And look at this, when you open, the diagonal became like big. I mean, you almost achieved 3.0. That's a very respectable size. And that I was afraid of, the diagonal is very respectable. Sometimes the angiography can fool you, just angiography about the size, because we always opt for, complete revascularization.
That was a still picture of what we got finally of the diagonal and LED, if it is visible. I had some problem with the video run, unfortunately.
One quick question to the surgeons again, from whatever I asked before. When you guys do lima to LAD, you guys also check the flow through the lima, like how much flow through the lima
Sure.
it comes, right? So does it have any any role or decision making things about whether to jump it or not?
No,
Just because of you want the lima to LAD to be the most successful one. So whether the flow is very good or not, it doesn't really matter here.
Definitely the flow matters. If the flow is very low, there's no point putting it. The flow should be at least 60 ml per minute. At the pressure around 100, 110 or 120. We measure it directly on the table without any flow meter, directly on the table. So usually it is always more than 60, around 80, 90 or 100, 120. So flow is number one thing. And in our center, our strategy is to put as many grafts as possible.
Yeah.
Whatever you see in the angiogram, no problem. I don't mind, but I'll put as much graft as possible. What I see on the table, that a vessel may not be visible on the angiogram. On the table, I can see a good vessel, or at least 1.5, I will graft it. And idea is that the nature of diseases in our part of the world is diffuse and narrow. In the angiogram, it looks like good vessels, but when you open up the chest and you look at the arteries, Asif will definitely agree with me. The vessels are, thickened, calcified, whitish, and so many things. So I have to find out the suitable healthy part to put the graft, and if the graftal vessels are there, definitely shall put graft.
Farooq bhai, excellent point. Excellent point. Because if it stays, it's like love. It is yours. If it does not, it never was.
Yeah.
All right. Thank you. Thank you, my respected surgeons and my cardiologist. Maybe we move to the next case with Nilesh.
Hello, everyone. I'm going to share my screen. I have a couple of cases. I think the surgeons will love to have some discussion on these cases because quite interesting pathophysiology that we see. I hope everyone can see my slide. Today, I'll be talking about assessment of left main stenosis under guidance of Professor Asan Chaudhry. So let me see if I can advance. Can everyone see my slides?
Yep.
Yes.
Okay. Perfect. So case one. So case one I have is a 72-year-old female who came in complaining of a sharp substernal chest pain radiating to her back. Past history, obesity, hypertension, pre-diabetes. Doesn't take a lot of medication except some medium intensity statin and some hypertensive medication with valsartan and metoprolol. Vitally, she was stable on presentation, and on initial evaluation with labs, her troponins were less than 3 nanogram per liter on the 5th generation troponin. LDL was 87 milligram per deciliter and normal creatinine. She actually opted for the myocardial perfusion imaging study route and then trying to see if really made sense to get on the angio table because she was a little skeptic about it. EKG over here, we see sinus rhythm, but what is very clear to us that AVR has some ST elevation, there are some ST depression, 2,3 AVF. And these changes, although they were there, they did not differ very much when she was stressed to peak exercise. In fact, she had a normal Lexi scan, as you can see over here. It's not the best study, but there are obviously no clear reversible defects or infarcts that can be seen. Given how prominent her symptoms were, we talked to her and we took her to the angiogram table. And we can see over here on the angiographic table on the left panel, we see the RCA, which is non-dominant and no luminal irregularities. But on the right, we see the left circulation. And what is very conspicuous to us is there is probably a hint of short left main with the ostial stenosis that we can think about. And this is what the whole case entails. So further angiogram showed that indeed there was presence of ostial left main stenosis. We were able to see dampening of the pressure while engagement. And as you can see, when we inject, our catheter buckles as well. So we were very careful in investigating this tight lesion. There are a couple of routes that we can use to investigate assessment of left main. One is the angiographic, the gold standard. But more recently, we have come up with a more understanding of the pressure system and also imaging. In this case, we use the pressure wire. We have the Phillips system over here, which helps us calculate the IFR. So this is the Omni wire that is introduced past the aorto-ostial lesion into the LAD. And what we see over here is a remarkably positive IFR at 0.84. with good waveforms, and this patient was subsequently sent for open heart cabbage surgery for ostial left main stenosis, that is IFR positive. Case number two today that the case number two I have is a little bit higher complexity than the.
Nilesh.
Yes, sir.
Sorry, just to interrupt. Could you just
Nilesh,
go back into the ECG?
Yeah. Yes, sir.
So Nilesh, so I don't know, did you, this patient did not go to the cabbage.
Dr. San, the other patient went, this patient went for cabbage, the other one we did, we stented. That's the case I'll present next. Yeah, she chose cabbage when we spoke to her.
Okay, I mean, regarding the ostial left main, we basically just believe you guys what you tell us regarding ostial left main, because it's not angiographically visible. If you got pressure damping or if you got those buccal signs and like you have done an IVA, so that tells us, and we just follow with that. I just want to comment for our juniors on the ECG. Other than the STE elevation and AVR, would you call there is a poor RF progression on this ECG?
Most
I'm
definitely.
just as a surgeon, I shouldn't be commenting on ECG, but
Yeah,
do you
definitely
think
there
it
is definitely there is
poor RF progression? Yeah,
definitely.
Yeah. So that's something to
Anti-vax.
highlight as well. Yeah. Okay. Thanks.
Case number two that I have is a 75-year-old male, and he
Really,
has.
just to clarify this poor ROA progression, this when there is poor ROA progression could be a variety of reasons accountable for that. And that also includes, as pointed out, that this could be an old infarct or is a body habitus or any other issues. But LV function on this patient was normal?
Yes, LV function was intact.
Yeah, and then I would request that we ostial only, I get really, really nervous with giving a diagnosis of ostial left main when the other vessels are okay. Because, in radiation, some fibromuscular dysplasia in some ethnic groups, aorto-ostial disease is probably more common, but we need to be very careful. Non-selective shot, semi-selective shot, nitroglycerin, and we need to go beyond that. Imaging studies, but in the cath lab, we have the obligation to prove by pressure wire or preferably imaging studies if we can, unless it is like super tight and you may worry about complication. But we need to be very careful for isolated aorto-ostial disease because it has huge downstream implications.
Hafiz bhai, would you recommend a CT scan for those patients to see
Okay,
the
so
proximal left main?
So here is the practical problem. And we have actually a couple of cases where we have seen the CT actually missed because it depends, because if it is fibromuscular and not a whole lot of calcium and very focal, the CT may even miss it unless you are very meticulous in terms of giving the feedback to the reader that I suspect significant coronary disease here. So the acquisition and the slicing and reading is very important for the CT. And sometimes the reader does not know and blinded, everything else looks so good that they just don't pay attention to the very focal aorto-ostial disease.
Yes.
Sir, I had a question, like in cases where you just have isolated ostial left main disease and you have normal LED, LCX, if you have to put a graft, which vessel would you choose? Would you put a graft in LED or LCX? Or the OM?
For both.
No, we have surgeons in the room.
Yeah.
So
Well,
I don't know what to
ask
answer.
if you ask me, I'll echo the comment of Dr. Hafiz that I'll ask for a CT aorta, especially to see whether there is any calcification. If the calcification is not there, I'll do a surgical osteoplasty. Means opening the aorta, going to that area and putting a pericardial patch graft, making a good opening up for the left main. And we have the experience of doing few cases like that, and on follow-up the patients are doing good, no problem there is. And another
So Farooq bhai,
yeah.
but that is a very good comment you just said. But I am afraid, and I had actually literally a physical fight with my friend who is a surgeon here, that they did aortoplasty, had a problem with the flow, came back, crashed, put a balloon pump, and I had to do the PCI of this. And at that time, I was probably more reluctant to do aorto-ostial. But now my recommendation is PCI first. But if you can do aortoplasty, that's probably the best. But you definitely check flow in the both system, right? Before you come out of the OR.
I mean, I have to confirm that there is no calcification. Next comes the fibromuscular dysplasia. And if it's not very gross fibromuscular dysplasia, we can put the graft and it works, hopefully.
Yeah.
And one more interesting story I like to mention here. We had a patient with left main ostial with given this nitroglycerin and everything. It did not work. So we recommended urgent CABG. The patient left for India, went there, and they also said emergency CABG. But patient was scared and he came back with the medication. After 2 years, he came back with some chest pain, not like before, but now he's still having some chest pain. So we said, okay, let's go and see the angiogram. And it was absolutely normal. Nothing was there. So I don't know what is the explanation. Maybe there is severe spasm at the orifice sound.
Yes, that's why I'm saying that we need to be liberal with the nitroglycerin. Yeah. And then also do some physiology and anatomy. And I usually do both, and probably Nilesh can show. If I'm going to do PCI or intervention or recommending, I need to be absolutely sure, particularly when the rest of the vessel, prox LAD is normal, and then circ is normal, and young, then spasm is very important to exclude.
Yeah. Right. I got a patient a few days back as well. Dr. Jahangir Kumar sir sent me a patient having ostial disease, and he just recommended for relook CAG. and I got everything is fine.
Yeah.
That could be.
Yeah, and when Nilesh was showing me the pictures, the first thing that I came like, did you give nitro there now? Because
Yeah.
looks, you know,
Yes.
the rest of the things are completely fine. So definitely we were fooled by spasm so many times before. So yeah, generous nitroglycerin injections and see how does it look, whether it changes or not.
All right, so this brings me to our second case. Um, this case involves assessment of, again, left main. So this is a 75-year-old male who came in presenting with angina for last 2 to 3 weeks, has history of Parkinson's and diabetes. On presentation, his troponins were mildly elevated on high sensitivity, 677 nanogram per liter. This on the old generation would be 0.67, so divided by 1,000. LDL was 76, and this patient, because of the angina, was given nitroglycerin loaded with aspirin and heparin and scheduled for a left heart cath. EKG on admissions, nothing that looks ugly to us, but then definitely there's some concern for some inferior Q waves, some mild ST elevations in the limb leads, and nothing too obvious jumping out at us otherwise. And here is the angiogram, LV-gram that shows intact LV function. Coming on to the coronaries, the right coronary dominant system gives off a couple of posterior lateral branches, no significant stenosis. And then we see the left system, and clearly over here we can find some suspicion of some stenosis, although there is a lot of overlap in this angiogram. And this spider view, LEO-caudal view, clearly delineates that a high tight proximal LAD stenosis was there. In addition, there is some concern. Is there some distal left main stenosis that is there in conjunction with the proximal LAD? Like Dr. Asan said, that having isolated left main disease without having any other distribution of disease in any other tree is rare. Actually, in the Syntax trial, only 10% of patients had isolated left main. Remaining 90% of left main patients had some other one vessel or two vessel or even three vessel CAD in addition to left main stenosis. Again, same angiographic pictures that we had to undertake. And given that now we identified this proximal LAD stenosis and that there was some concern of distal left main stenosis, we needed additional tools to figure out whether stenting would be the best strategy or sending the patient for a Lima graft would be the best thing. We had involvement of of our cardiothoracic surgeon on the table to discuss, and we proceeded to further interrogate this distal left main stenosis, and we used the IFR route of testing. Because the LAD was so tight in angiographic appearance, we decided to land our omni-wire or the pressure wire into the left circ. And our theory behind it was if the IFR in the left circ system was good enough, that means that there was no stenosis in the distal left main. Otherwise, it would have given us some signal of IFR low in the left circ system. So over here, we introduced our omni-wire down the left circ and showed a very robust IFR of 0.99. It's a near normal IFR. Subsequently, we undertook angiogram, angioplasty of the proximal LAD, did balloon angioplasty, finally landed up with a Zotariolimus stent, and this was the final result. And this was the final result I can show you. But more interestingly, we had to prove to a surgeon that, hey, the distal left main was not implicated in this lesion. And we again reintroduced the omni-wire into the circ and then subsequently in the diag as well after placing the stent. And what we were able to see was post-procedure, the IFR in circ dropped down to 0.95 from previous 0.99, but still above the cutoff of 0.9. And IFR of the LAD was also robust at 0.95. And this was the final angiographic picture. I will pause here for discussion on this case.
Definitely, there is a left main disease, right?
Yes, sir. There's something
But
over
it
here.
is not significant. That is the question.
Yes, sir.
And
Yes,
that
sir.
was not taken care because IFR was fine. That is
exactly. Exactly, sir. So we had concern of left main stenosis. Over here, you can see it much more clearly. There is some distal left main stenosis that we can see on our cranial shots that was negative on the IFR testing. And finally, I will bring upon our third case, which takes a step further in with. Yes, sir.
Can I just ask a question? How would you explain the view on the left main where you actually can see a disease on the distal left main, but your IFR and all the other tests, and also especially on your spider view, you couldn't actually see any disease? So for our junior colleagues, could you explain how one angiographic view can show you such a significant disease, whereas other view you can't see that?
So rule of angiography is you need to obtain orthogonal views, at least 2 views, to get an assessment of any kind of lesion. Because viewing it in one way, one view right over here, you have some assessment. Hey, could this be a 50% lesion over here that on the cranial view looks 50, but on caudal view, which is the orthogonally opposite, I'm not able to make sure of that high degree of stenosis. I hope this answers the question.
Yeah, so basically that means you have got an eccentric plaque. You haven't got a circumferential plaque. So what you've got an eccentric. So if you see in one view, you could see the disease. Whereas if you look at the other view, you can't see it at all because it's a 2D images on a 3D structure. So it's just important for us to appreciate the angiographic finding. And that's why I personally believe the functional study is very important for us to decide about any revascularization strategy.
One quick question.
I have a question, please. Whether IVAS was done for this patient because angiographically, if it is 50%, if left main, so angiographically it should address the lesion. But because of the IFR, it was not addressed. But whether
so let me clarify this, and that I think maybe I can reserve the comments until this last case, and
yes,
then
sir.
that is exactly the reason for that question we are presenting the case.
Case, yeah.
Okay, next one.
So this brings us to our third case. A 59-year-old female that was evaluated as a part of a pre-renal transplantation procedure, and she has history of diabetes, hypertension, and creatinine 5.2, eGFR 8, hemoglobin 6.5, LDL 28. So you see not a high burden of disease that it's perceivable on a pre-cath risk profile. EKG over here shows mild changes consistent with towards LVH, some high voltages, but nothing out of ordinary. Some muted T waves that you can see all throughout the precordium and in limb leads. So angiogram over here, the right angiogram, angiogram of the RCA shows that it's a dominant vessel with one large PLV vessel. And this is where I land ourselves. Again, an osteal left main stenosis that we can see. It's a codominant system, a huge circ system, a huge LAD system, and definitely there's some concern for angiographic left main stenosis. Further delineated, now you can appreciate, like Dr. Sadak said, that on 2 views, on this view, it looks a lot more severe, maybe up to 90% stenosis up here. We investigated this left main stenosis by parking our IFR wire into the LAD. We first measured the IFR, which was at 0.9. And since this was right at what we call the yellow zone, it's not the red, it's not the green, it's the yellow zone, the gray zone, we proceeded to further investigate this by doing an FFR evaluation by giving IV adenosine instead of intracoronary adenosine. And you can see the FFR is positive at 0.75, which is below the threshold of 0.8. Again, this patient was brought up with our surgeons to figure out what would be the best approach for this patient. And given that the disease was located to the aortoosteal side, did not involve any other coronary trees, a low syntax score, and hopefully expediting her recovery to the renal transplant, we opted for left main PCI. And the way that we went around doing the left main PCI, we did the balloon angioplasty first, and then we lined up our balloon to place our stents. And we can see an excellent angiographic result after placing a everolimus 4.0 and 8 millimeter stents. And what we followed this up by is the much anticipated IVUS. So we do have IVUS for this patient, and we can show you that we achieved a good minimal stented area of 11.3. And coming to the aortoostal area, you can see over here, we don't have a lot of disease that we did not cover. We didn't have concerns of any malapposition or small MSA post-procedure. So we were able to achieve high MSA post-procedure, which translates to hopefully low incidence of instant restenosis in patients with left main stenosis. And this was my final slide. I'll try to play this if possible. Let's see if I can play this. Any questions from the panelists and the audience?
I actually have a question to my cardiology colleagues. Because I have come across these situations quite a few times and I still don't know what is the right answer, especially when patients are waiting some sort of surgeries, like at the cancer operation, commonly lung cancer or any other malignancy, or like this patient waiting for a transplant. The argument comes about stent and surgeries that you have to put them on DAPT, and that precludes them having a surgery on an early stage. So do you guys use any particular stent where you can actually stop the DAPT quicker? Because I don't think any of the surgeons would be happy to operate on a major malignancy surgery on patients who are on DAPT. Whereas if you do surgery, you don't need DAPT for those group of patients, and they can have. So I mean that argument comes few times. So I'm just wondering, what is your practice in your centers?
Can I take the question?
Yes, please, Kaswai.
Yeah. Excellent case, excellent three presentations. Really appreciate. To answer your question, nowadays all the modern drug-eluting stents, we can use double antiplatelet therapy for 1 month. After 1 month, we can put it off. This is also proved in several trials. So it's not a big deal with any particular type of stent. All the stents like Medtronic's, Resolute, or Abbott's, all of them say 1 month antiplatelet, then we can stop it. So maybe after the transplant, we can again restart our aspirin. Maybe we put it off before transplant, 5 to 7 days. So you can do it nowadays. Just a comment about this case. My one small comment. Usually in left main, I would prefer to put a bit longer stent, not 4.8 or maybe 4.15 or 4.12. Because sometimes what happens, if you put a stent, a short stent like this, it does not anchor in the left main, and the stent comes out with pulling out of the guide catheter. So definitely Hafiz Bhai is a very expert operator. He knows where to put and how to put. But for juniors, I would say that 4.12 or 4.15 would be preferable to have more anchor on the left main, so that sometimes when you pull you out of guide catheter, or the stent might come out. Because I have come across 1 or 2 cases like that. And again, wonderful presentation. Nilesh, good presentation. Thanks.
So let me clarify one thing, and thanks, Kaiser. So because of the endothelialization with the newer strains, with thin struts and the newer drugs, I think 4 weeks is good enough, and then continue with aspirin. However, in the kidney transplant world, I work very closely with them. There are some living donors, and there is some diseased donor, and when they get called, you cannot stop the DAPT and then go for the transplant, because nobody is going to wait for 5 days when the donor kidney is available, and the person will miss. So when I pointed out to our surgeons a few years ago, they said, we'll do this transplant on DAPT. So it's not a problem for our hospital. We are doing it on DAPT. So because we don't know that when the patient will get the kidney. So if we want to, we can continue with the DAPT. And then the question about the size, yeah, it is a very good point Kaiser mentioned. And if you want to really make sure, some people even follow Zabo technique and all that, but we checked, and Nilesh did not show this, we did a little bit of pre-IVAS, and then it was very focal and very short segments. So we thought that we will be able to get away, because the left main overall was that long, that not that long. So yeah, good point, Kaiser. Yeah, but we are lucky, and I think there will be debates, and Farid Shakil is not here. So usually when I call the surgeon, our surgeon, what heart team approach, he convinces everybody for cabbage. I don't know how he convinces. So I'm very careful about heart team approach.
Can I add one thing? Whether with double antiplatelet surgery can be continued. One case we did after putting a stent of a patient with acute myocardial infarction. We put the stent at the same time patient was bleeding from the urinary tract, and there was hemangioma, and that was addressed after 3 days. They did the surgery with both antiplatelet, and patient was fine and still doing well that time. And so I think some surgeon can do with double antiplatelet as well.
Yeah, no, absolutely right. And the question I wanted to make, and the point actually I wanted to make is every trust, every hospital has got their policies about these things, and every department has got their own policies. And like in emergency situations, we do everything. I operated on DAPT patient on loading dose, and aspirin and clopidogrel come with type A dissection. There is no other way for me, so I have to operate. Patient on apixaban, I have to operate. There's nothing I can do about that. But in elective cases, whether you have got, but I think it's very important, because sometimes my cardiology colleagues are a bit reluctant here. So I've got few points now. I'm going to fight with them about this. Thanks.
Right. I think nowadays, because I had this just similar question yesterday, like stented the left main, and the question is when we should stop the DAPT for this patient to go for transplant. And the transplant surgeon said, they don't really mind. If they get a kidney, they will transplant, do the surgery, and then just go with it. They're not going to stop it. So going back to one last question, I think that question was already asked for the second case. What did you have any decision making between choosing your FFR, IFR, the physiology versus imaging for that case, particularly? Have you any point for? I think the patient was in an NSTEMI, right?
Yes, mild small elevation of troponin, 600s, and it was stable.
Setting
yes.
ACS, was there any thought process of using imaging versus physiology?
Excellent point, but there are a few points, technical point of consideration that I think I will bring out in this case, because this gets a little bit more technical. One thing is the IVAS catheter is a little bit bulky, and I will show you how tight this proximal LAD stenosis is. So herein again, it causes a little bit more anxiety on the operator part, and also we may land up in a case which was elective to turn into prox LAD dissection. So using bulky, which have low crossing profile, may be a little bit more challenging in this case. The second thing is IFR wire that we have over here. One, it's pretty quick and easy to get assessment without having setting up for the IV adenosine, waiting for the 4-minute infusion, waiting for the appropriate drop in pressures. So IFR gives us a relatively quick information and assessment of this lesion. And then the third thing that definitely I agree that in the milieu of ACS, where it is a little inflamed milieu, you can have pre-existing hyperemia, which may falsely increase the FFR value. So those considerations are always there. And IFR in these cases, actually, I do have some presentations, some slides on this case where they were able to validate the IFR data set in evaluation of left main stenosis because of um,
But
this is what I have.
one point is, Nilesh, you can, since you're just doing the left distal left main, you can send your IVUS catheter to the SART to assess the distal left main thing. You don't have to really go to the LAT to measure
To figure out. Yeah.
Very nice case, Nilesh. Good job. Well done.
Thank you. Thank you, everyone.
Mashwar, if that's okay, I'll just quickly go through my case now.
Quickly go through your
Yeah.
case. I know it's
I think we had enough coronaries now. Let's talk about something else. Otherwise, there is actually never-ending discussions. So the case I'm going to present, very simple, but difficult to make the decision. So let me see if I can share my screen. Okay, let's start sharing. Can you see the PowerPoint slides by any chance?
yes.
Perfect. 75-year-old lady, very fit and well till last year. She's actually came to see me in my clinic. Worsening symptoms of shortness of breath for only 1 year now. One and a half year, but it's really getting worse now. NYT is about 2 to 3, and it is worsening rapidly. And no chest pain. She had a past medical history of a stroke, which is about a year and a half ago, but there is no residual weakness. There is a CT reported, there is a small infarct foci, and she has got history of atrial fibrillation and has been on apixaban for about 2 years now, which is about a year and a half. So I'll show you first the angiogram. Can you see that?
Yes.
Good, perfect. So, I mean, anything to comment on this angiogram? Anyone? Tanvir or Nilesh, if you guys want to just talk us through, you're more expert on angio than me.
Yes, sir, most definitely. Uh, uh, these are a couple angiographic craniocordy views. They show tortuous. One thing I have to comment is even the proximal segment of LAD is quite tortuous. I don't
Yes,
see any visible angiographic stenosis.
you're
Maybe.
absolutely right. There is none, and it's, as you can see, this is a left dominant circulations. So there was actually, it's a very, very small non-dominant right, and there is no obvious disease in the coronaries, which can explain that she doesn't have any symptoms of chest pain. The next thing I want to show you is her ECG. Can you see the ECG here?
Yes, sir. It looks AFib.
Yes, perfect. So as I told you, she has got atrial fibrillation. She is on apixaban for that. The only thing to highlight as a surgeon, but is important for us to look at in ECG with patient with AF, is that whether we actually have a fibrillatory wave in lead V1 or in lead 2. Because if lead V1 and lead 2 basically are flatlined, then there is no point on doing any intervention on their atrial fibrillation, because those atrial fibrillations are very long lasting and they don't get better. But if you got a fibrillatory wave like this, then they actually have got a more prognostic benefit of if you intervene on their atrial arrhythmias. So that's what we were just trying to see on this ECG. And now I'm just going to show you the echocardiogram. Tell me if you can see the images when it's coming. Okay, can you see it running?
Yeah.
Is it running now?
Yes,
It is right.
we can see the parasternal
Okay.
short axis view intact EF.
Very good.
I don't see a giant left atrium, but I guess in more views with more gain, I
Yeah.
will be able to comment.
Anything obvious you can see on this echo?
I don't know whether it's a organic mitral stenosis I'm looking at. That could be a second question I ask myself.
Yeah. I mean, there are some calcification of the mitral, I agree. But the most prominent thing, you can see some restricted movement of the aortic valve. So, and some hypertrophy of the ventricle as well. But as we carry on, we'll see. colored Doppler here.
There's some AI going on there.
Yeah,
Yeah, there is AI going on, and there are some mitral regurg, but not significant. I mean, in this images, some view you can see the mitral valve is opening well. I think the calcification is probably in the posterior mitral annulus, like a mitral annular calcification or MAC. Tricuspid inflow, which looks okay. Trying to measure the tricuspid. Not a very good view there. As you can see, very nice short axis view of the aortic valve. This is a tri-leaflet aortic valve. There are restricted movement. The right leaflet is slightly moving, but the left and this is the non and this is the left. The left and non is more or less fused, but the right is slightly movement going on, but definitely the movement is restricted. You can see there a bit chalk on the valve, calcified looking aortic valve. So you probably have an idea by now that she has got aortic stenosis. Short axis across the LV, functions looks good, as you can see. And now you can see the left atrium looks reasonably in the big size. The mitral valve looks open reasonably well. There are some calcification like MAC, but can't see any AMR, mitral stenosis. With the color flow, we can see if there is any MR. They're probably trivial to mild, nothing significant. In the two-chamber view, you can still see. So now in this view, I'll probably try to see if I can run it a bit slowly and show you the tricuspid jet. As you can see, there's quite a big tricuspid jet. And no, let's see if I can take the images. Okay. So so you probably can appreciate a bit better the tricuspid regurgitation here. There you go. Trying to measure the TAPSE. Okay, mitral inflow. Looking at the LVOT, that's the continuous wave Doppler. And there, as the patient is in AF, that's why you're getting different level of velocity across the valve. And as you know, in case of AF, you need to get the maximum velocity you get across this aortic valve. That's what you need to assess here. So they have done multiple views, multiple velocity measured, and the recorded maximum velocity was 4.08, which falls into the criteria of severe aortic stenosis. That's the Vmax across the aortic valve. That's it. So you still can see left atrium, right atrium reasonably on the big size, not significant MR, but there were sign of significant tricuspid regurgitation, subcostal views, and they're looking at the IVC inflow pattern on respiratory variations. They've done a planimetry. ADA is about 1.03. I'm not very big fan of area on measurements of transthoracic. I think TOE is much better on this. But as I say, the measurement across the aortic valve Vmax was 4.08. That falls into the criteria of severe aortic stenosis. So we have got a 75-year-old lady who presented with worsening symptoms. She has got severe aortic stenosis. Symptoms is very significant for last 18 months and NYHA 2 to 3. Now, on the basis of this echocardiogram finding, the question comes now, what should we offer this lady? Should we offer her optimized medical treatment and then keep it surveillance on the echocardiogram? Should we offer her TAVI or TAVA? Or should we do an AVR and a clip on the left atrium to read, because she already had a stroke, so we need to make sure somehow we have to clip the left atrium? Or should we address the aortic valve, tricuspid valve, and do an AF ablation surgery? And let's see what you guys think about that, and then we can come to an agreement, hopefully in this MDT.
Did you get a gradient across that zone?
Yeah, so Vmax was about 4.08, so peak gradient was about 65.
severe.
Mean was 4. Yeah, so it falls into just about severe.
So symptomatic and severe AS.
Yes.
What
But
could be the
the
cause for tricuspid regurgitation for this patient? Is this a valvular or
no, this
function?
this is very important point. That's what I wanted to highlight. The reason for this patient to have this TR is entirely driven by AF. Because of the AF, she has got annular dilatations, which is causing the TR. She's got a good lung function. She's a very fit and well. Up till 18 months or 2 years ago, she used to play badminton. Now she suddenly got worse. The important thing to highlight here is that the atrial fibrillation has driven her symptoms much worse, which she did not have before. I think, as you all know, aortic stenosis is a very slow progressing disease. So I'm sure this 4.08 or 4 meter per second been there for a year or so. But the reason she really getting symptomatic now is because she has turned into AF and she has lost her atrial kick and she has got lost the cardiac atrial portion of the cardiac output, which is making her much significant on the symptoms.
Okay.
So the question comes now is, shall we just address the, I mean, whether she needs an intervention or not, number one, because she's 75, though she's reasonably fit. Second, if we do intervention, whether she should be a candidate, because anyone above 75, we need to think about whether they should have a TAVR or aortic valve surgery. Or if we do surgery, then what would be the surgical options?
Dr.
Is
Sadak,
AFib
I
is
had a
permanent
question.
AFib or AFib is it a permanent AFib or because LAS size looks pretty big, and also when they did the cath, they have the right heart cath.
No, so there's a very important point, Hafiz Bhai, is that the left atrial size is big, and that's why I was showing you the ECG, because previously we had a rule of thumb: LA more than 5 centimeter, AF more than 5 years, no point of doing any AF ablation surgery. But we have come away from that because the evidence showing that that's not relevant anymore. And especially what we look at the ECG, if you got this fibrillatory wave in the lead 2 and V1, those are the patients whose AF, if you fix them, there is a good chance they will come back to sinus. And as this patient, particularly, all the symptoms are driven by her AF, not only by AS. So I will be in more favor of addressing the AF rather than just addressing the aortic stenosis.
I totally agree. And another important point, which I don't know whether she has, the atrial fibrillation can modulate the left atrium so much that we can develop the mitral regurg from the annulus. And
Fantastic point. Yeah. Exactly the point I wanted to go to there, but Hafiz, we've already been there. But I'll address it later. Anything from anyone else?
I just had one comment, and especially
Yeah.
when such disease pathology changes in a very short period of time, our suspicion to rule out amyloidosis should be high in such patient when you are seeing AF, rhythm issues, and also very characteristic, you can see a biatrial enlargement on the echo. So our suspicion to rule out amyloidosis should be high. And sometimes these patients can come out of all these things when they are treated with the right therapy without need for intervention.
Just for the audience, I just wanted to clarify one thing. What Nilesh is saying, a cohort of patients with the aortic stenosis presenting with this kind of, there is the prevalence of transthyretin amyloid. And particularly if they have any carpal tunnel or anything, we need to be vigilant. Some may have the diastolic dysfunction parameters, and when you do the pyrophosphate scan, you may see them positive. What you do with them, that is a different question. But it's reasonable to address the AF and then the aortic valve first.
Right, and I think, it's like here, as you mentioned, she's a well-fitted, well-functional female, and she is, how old is she? 70 something, right? 75. So I'm assuming she's like probably moderate or low STS score, right? So it's sort of like a first choice. The TAVR, yes, you can offer TAVR to her, but as well, we so far have data for TAVR valve longevity. That's what we are really focusing nowadays on, the longevity of the TAVR valves, because she's 75, and here in the US and UK, the average, the longevity of patients almost reaches 90s. That means the TAVR valve in
at least 15 years we're looking at,
Right. So whether we will get a good life out of TAVR valve or not is gonna
Yeah.
be something that we need to also ask those questions.
Yeah. No, fantastic point, Rashid. Before I go into what I have decided, I just wanted to see if you guys, anyone else have got any questions about this case.
Go ahead.
And
I'm
then
dying to know what you did.
Okay, Hafiz, right? Thank you very much. I'll ask Farooq sir at the end to see if Farooq sir agrees with me. I actually haven't operated on her yet. She's still on my waiting list, and as you know, at the moment, it's taking a long time for us to get through these cases. My plan, after actually I had discussed her case recently in our MDTs, and my plan is to offer her aortic valve, tricuspid valve, and AF ablation, because I think this tricuspid regurgitation, which is severe at the moment, that we will just put a tricuspid ring, but she will need a full AF ablation, because I'm very convinced these are symptoms driven by AF along with aortic stenosis. If we can get her back to sinus, if I can't get her back to sinus, I'm sure that within 5 to 10 years time, she's going to come back with severe MR if the AF persists. That is what Hafiz Bhai was trying to say. And it is really important sometimes to identify this pathology, because if the patients are on AF and you are sure that you won't be able to fix the AF, then have a low threshold to put a mitral ring, because otherwise they're going to come back with 5 to 10 years time with severe MR. Farooq sir, would you agree to operate on her aortic and tricuspid valve together? Yeah.
I think Farooq Bhai may have left.
Yeah,
No, Farooq sir is there. Yeah.
Oh, Farooq Bhai is still there.
Yes.
The only problem I will have to think of in Bangladesh, because if it is of 75 years in Bangladesh, first I have to think of whether she is going to tolerate the surgery.
Exactly.
Checking her
Exactly.
respiratory systems and renal functions and everything. And if she is fit, if she can, take this surgery, then probably surgery is the best choice, as I do agree with you. Aortic valve, the tricuspid repair, and the difficult ablation or modified mesh, which makes sinus, and the patient will definitely have a better quality of life.
Yes.
ফারুক ভাই একটা জিনিস বাংলাদেশে কিন্তু আমাদের একটু বেশি অ্যাক্টিভ হইতে হবে, কারণ 75 হইলে বলে যে ভালো মন্দ খাওয়াই দেন, কিন্তু
ওইটাই বিপদ। বাংলাদেশে আরেকটা বিপদ হচ্ছে এখন দিস ডেজ, সরি ফর মাই কমেন্ট, এখানে আমি কাউকে ইডিয়েট বলছি না, একটা ইডিয়েট সিনড্রোম বাংলাদেশে খুব প্রিভেল করছে দিস ডেজ। ইডিয়েট সিনড্রোমটা হচ্ছে ইন্টারনেট ডিরাইভড ইনফরমেশন অবস্ট্রাক্ট দ্য ট্রিটমেন্ট। So what people do when I say something, just go to the Google and say, seeing this thing, they start asking or start contradicting, why not this thing, why not that thing, and becomes very much difficult to make them understand what I am learning over the 30, 40, 55 years, 45 years. They want to learn it within 4.5 minutes, and they want to start arguing. And it is difficult to convince them. If they are convinced, আমি যেটা করি সাধারণত ফুল এক্সপ্লেনেশন দেয় এবং মর্টালিটি রেট সহ সবকিছু এক্সপ্লেন করি, these things may happen. If you agree, I'll go for surgery. And on principle, I always consider surgery should be the last choice, whatever be the situation. এই প্রেক্ষিতে, বাংলাদেশের প্রেক্ষিতে এটাকে আমাকে দুইবার চিন্তা করতে হবে। পেশেন্টের পার্টিকে, পেশেন্ট না শুধু, পেশেন্টের পার্টিকেও কনভিন্স করতে হবে, এবং এট দ্য সেম টাইম পেশেন্টকে কনভিন্স করতে হবে যে স্পেশালি এইসব এই যে মহিলারা পরবর্তী পোস্টঅপারেটিভ পিরিয়ডে কোঅপারেট না করলে স্পেশালি লাং কমপ্লিকেশন হয়, এবং সেখান থেকে সেপ্টিসেমিয়া, মাল্টি অর্গান ডিসফাংশন এসব শুরু হয়। সো টেকিং অল দিস ইন কনসিডারেশন, আমি বলবো বাংলাদেশি কায়দায় সাবধানে পা ফেলা। বাট regarding the treatment, I completely agree with Asif যেটা বলছে সেটা, aortic valve, tricuspid repair, and at the same time treating AF.
Yeah, no, Farooq sir has made a very good point. I usually, I've seen a funny joke about this. The patient coming to see doctors, and there is a board written outside that if you have gone through Google and come for a second opinion, check how. So that's what the patients are doing. They're coming for a second opinion after checking. But Farooq sir made a very good point, because his experience of 30, 40 years doing cardiac surgery, you can't justify just doing 10 minutes Google search and asking the question. The other point I just wanted to make on this particular case, that previous history of stroke, it fools are also into a bit higher risk of further stroke. So the left atrial appendage has to be addressed. And if we can't do even AF ablation for logistic purpose, at least the left atrium should be clipped, because otherwise she's gonna be having further history risk of stroke. So that's from
But I wanted to thank you because to give this thought process on the tricuspid, because somehow it is not that well respected valve, the tricuspid valve. But I would request probably the junior guys to read the Adam from Mount Sinai did a very good review on tricuspid valve in Jack. And I'm very happy that Sadiq, you took this consideration to address the tricuspid valve and come out good with the overall. Excellent choice.
Thank you very much.
So I think Nilesh was a little curious about to know whether you were planning to do some amyloidosis testing. Although I say the echocardiogram, usually with amyloidosis, the echocardiogram gives a way more granular pictures, although that's not really very specific. And then the EKG also is not, I don't think that was suggested. I don't remember exactly.
Yeah, no, that's because when the MDT happens, we have got cardiologists specialized in echoes who usually present these cases. Yeah, so they had a looked at it, and if they have any suspicions, they usually highlight, and then we do the particular test. But they haven't addressed any issues, so we just kept it as it is. Yeah.
And it was not a low voltage EKG as well, right?
No.
Right. Any
Although
question?
be careful, it is a lowish voltage EKG because the amount of LVH I was expecting, I did not see that in the EKG.
Right. I don't remember the whole EKG though, but
excellent case.
All non-specific. So if you are really suspecting, yes, and that's true that there's a big cohort of patients who had, we have done TAVR on them, we have or done surgery on them, and then patient really didn't do good because they had amyloidosis, and multiple times it came to our attention after we did something for them. So excellent case, and I think this is all I had. I'm not gonna do another one here to boredom everyone. It's already 1.5 hours, quite late in Bangladesh. I just want to thank all of you. I want to thank Tanveer here, and Tanveer, we are looking forward to have you back again at any time. Just in touch with us. I want to thank Nilesh. Nilesh, you're a very, very smart cardiologist, and you're going to be a very smart cardiologist in future. I have no doubt about it. Excellent presentation. And Asif, thank you so much for arranging this meeting with us. And this is always a learning process for all of us. And I would like to particularly thank Dr. Shafiq, Dr. Hassan, and Dr. Kaisan Nasrullah, and all other participants for this wonderful session. So with saying that, if is there any comment from Dr. Shafiq or Dr. Nasrullah and Dr. Farooq, sir, anything for future aspect?
Now we want to thank you, Mashrafi. You did a wonderful job in moderating and organizing this. Thank you so much.
My pleasure, Hafiz bhai.
Thank you very much. Nothing else. It is really very wonderful session, and we learned a lot. And definitely
conclusion, at the end, I like to mention, we should, with the surgeon should know it with friendly or relation, we should have friendly relations with our cardiologist, because at times we have to get away, we want to get away with it, then we need the help of our cardiologist. And most of the time when we discuss together, cardiologist and our surgeons, we discuss together, usually very good outcome comes out of the whole treatment procedure. So I like these things, and I always try to maintain good relationship with our cardiologist friends. And I think Shafiq and Kaisan Nasrullah will admit, though they are working on the student, I try to make at least good friendship with them so that I don't end up with problem. And it's definitely
we also like to be friends, because when we are in trouble, you are the savior.
Yeah, right. Vice versa.
Yeah, Asif, go for the valve for this lady, and when the valve fails, send it to me for TAVR, okay?
Yeah, she would love a trip to. There is a hand raised, though, Mashrafi bhai.
Nadia.
Assalamualaikum, Sadia Appa.
Walaikum salam. Sorry, closing hotse ami on call, so I was talking to my fellow, so I couldn't participate actively, but I was listening to it, most of it. Thank you so much. It was really, really wonderful. I learned a lot. Just two comments I want to make. I wanted to make the comment when the case was presented, the FMD one. Hafiz Bhai was right. It's very difficult to diagnose with CT because there is not much awareness of FMD and spontaneous coronary artery dissection, even in radiology. But this patient, if presents again with chest pain, the first modality in our hospital is to do CT coronary angiogram to see the vessels. And with good scanner, good quality scan, you can diagnose this disease. Another comment I want to make about amyloidosis, that's a really good thinking process. With lots of aortic valve stenosis or concentric LV hypertrophy, even HCM cases, we are more and more recognizing that their underlying pathology is amyloidosis. And you can do cardiac MRI, and if it is pretty obvious, it's obvious, and you can have, as a diagnostic tool, you can use it for the juniors. Thank you.
One quick question since I got you here. I have a TAVR patient. Gradient went up very, very quickly in like 6 months. What would be the best test to look for subacute valvular thrombosis, leaflet thrombosis? Is it a CT or is it an MRI? CT based.
Definitely CT. Definitely CT, 100%, yeah. But you need to specifically ask the radiologist that you are looking for valvular complications, particularly halt or thrombosis. And the technique is slightly different. We acquire it retrospectively and image the whole cardiac cycle. And quite confidently, you can exclude. Even yesterday, I had a mechanical valve thrombosis, very small, and but patient had stroke. So we imaged 1 month apart and was looking for volume reduction, because the other thing is you have to treat it maybe surgically because you don't want another stroke in that patient. So yeah, even mechanical valve, although there is a lot of strict artifacts, you can confidently exclude or diagnose valve related problem with CT. MR is not as good because of resolution difference.
Thank you. Thank you so much.
Thank you.
Thank you very much. I just wanted to say thank you to Farooq sir for again joining. Sir, we have got another session in cardiac surgery next week, and Sadia Appa as well. Just wanted to confirm you guys. I'll update it in our website again. But thank you very much for this joint session, Mashrif Bhai. Hopefully we'll do it again on our next one.
Sure. Thank you, Asif. Thank you, everyone.
Thank you, sir.
Thank you.
Thank you.